All right, cystine concentrations. What do they look like in urine? Urine cystine is, in general, you like to think about what's a goal of cystine concentration. Generally, people say you'd like to keep it under 250 milligrams per liter. The higher the pH, the better off you are. Look at this from our patient population. And you'll see that a significant fraction of the urines we receive at Litholink, and most of them are not the people who just got their first diagnosis. These are people who would get repeated urines for trying to help with therapy. A large number have urine cystines over 300 milligrams per liter, which would generally be considered too high. What are your goals in therapy? If you're going to try to maximize therapy by just knowing the cystine concentration and the urine pH, I would tell you, my guess, that if you could keep your urine cystine concentration under 250 milligrams per liter and keep your urine pH above 7.5, those are really good guidelines for to try to prevent kidney stones. But again, they're not absolute because we don't actually know the solubility from most people's urine. Next slide. David showed you a similar slide. Again, this is about cystine, the drug, and the formation of a more soluble cysteine drug complex. I want to make one point here. The other thing that we don't know, you have the pH solubility curve, you have a cystine concentration. You don't always know the effect of the drug on the cystine levels. And I'll tell you this, and you know, there's going to be limited access to this knowledge from your patients and from your treating doctor's point of view. What you get when you're on the drug, the knowledge that you know about your urine chemistries when you're being treated with the drug, depends on how the cystine is measured. Cystine can be measured by a variety of ways. What's called liquid chromatography. It can be measured by gas chromatography. A simple and still commonly used method is an old chemical method, so-called a colorimetric method, in which the sulfur bond is broken, and basically you measure the amount of sulfur reactivity in the urine. You think, well, why are you telling me this? Because I want to point out to you that if you're measuring the amount of sulfur reactivity in the urine, the drugs have sulfur reactivity. And if that's how your lab measures cystine, which is not, there's nothing wrong with that, you will not get an accurate cystine measurement in the presence of these drugs. So it's quite complex as to how you want to follow therapy. Even some of the HPLC methods don't necessarily account for how much of this complex is formed. Many of the HPLC measurements, when they want to measure cystine, they break all these sulfur bonds. And so you can never know how much cystine was excreted with drug. So it's often be very hard to measure these things. Next slide. So for all of you who sent in urine to Litholink, and I appreciate it, and it's specifically for the study part of it that got us going, very appreciative that you bothered to take part. What do we do with all these things, and what do we call cystine capacity and cystine supersaturation? When we take the urine, you folks send us a urine, we take the urine, not the one that's been alkalinized, but the one that came in, it's a natural pH. We take the urine and put a small amount in a beaker. And then we add cystine crystals to the urine. Those cystine crystals have one of three things happen. If the urine is below its solubility point, or so-called undersaturated, such that the urine could take up cystine from these cystine crystals will begin to dissolve. And they'll dissolve and dissolve until more and more cystine is released into the urine, and they become at equilibrium. And now they've reached their saturation point, or their solubility point, and they stop dissolving. This usually takes about 48 hours to come to equilibrium. And if we measure how much cystine got dissolved, we know how far away from the solubility point the patient is. The lower or the farther away from the solubility point the patient is, the better off they are. The less chance they'll form stones. This can be referred to as either cystine supersaturation, which would be an undersaturated urine, or it can be referred to as cystine capacity, which is how we talk about it in litholank, which is what's the capacity of the urine to take up cystine. Okay? If the crystals neither dissolve nor grow, then this urine is its solubility. If the cystine crystals that are put into the urine grow, become more plentiful, the urine was supersaturated. It had an excess of cystine just waiting to crystallize. We accelerated that crystallization by putting new cystine crystals in there. The cystine concentration in the urine will drop as these crystals grow, and we will see that change. So we measure the cystine at start, we put the crystals in, after 48 hours we measure the cystine again. This takes into account the activity of the drug. The drug will now tell us if the drug is actually functional and working in preventing or changing the solubility characteristics of the cystine. We'll see it reflected in the cystine supersaturation or the cystine capacity. You want a urine that is undersaturated. You want a urine that has a positive cystine capacity, that is not going to crystallize, but in fact could actually tolerate having crystals added to it, and those crystals would actually dissolve. Next slide. So what do patients actually look like? Well, Dave will point out to you the capacity. We like to see a positive number. Again, from a large number of urines, it's like 230 urines, I think. About half have a positive capacity. But unfortunately, a large number of patients still have a negative cystine capacity, which is a tremendous risk for crystallization of cystine. And so the therapy needs to be much more aggressive. And I would suggest to you that you don't want to sit right near the 0 point. You want to be well above it to really protect yourself from cystine stone. Probably around a capacity of 100, which is a distinct minority of random patients sent in for urine testing at litholank have actually achieved. So the therapy, countrywide, this is not just my patients or David's patients, but countrywide, needs to be better for cystinuric patients. Because I can tell you, you're sitting over here, you're going to form more stones. And unfortunately, a large percent of the cystine patients still have too many stones.